Welcome to the CCRN Neurology Review. I'm Brent. Let's get started. The neurology section on the CCRN tests contain a lot of testable areas, such as aneurysms, brain death, congenital neurological abnormalities, encephalopathy, so-and-so, all the way down to stroke. Starting off with anatomy review, there's two things that you need to know on the CCRN test: the transtentorial shelf, the foramen magnum. These are two openings in the skull. You need to really understand what those openings are there for and what happens when the brain herniates through one or the other or both. The first is the transtentorial notch, which is a small one. It is located here. This is the upper opening in the skull, and it's typically smaller. The second one is the foramen magnum, and is much larger than the transtentorial notch. This is where the brain connects to the spinal cord. One of the testable areas on the CCRN test is the cranial nerves. You don't need to memorize these. However, they are and will be implemented into the questions. It's important to note that all cranial nerves, with the exception of 1 and 2, originate from the brain stem. Cranial nerve 1 and 2 originate from above the brain stem. The ones in red are the ones most tested on. Cranial nerve number 1, the olfactories or smell. This is most often associated with the basilar skull fracture. Cranial nerve number 2, the optic nerve, is associated with sight, not pupil reaction, so remember that. If you get a question on pupil reaction, you're not talking about the cranial nerve number 2, you're talking about cranial nerve number 3, the oculomotor nerve, which is the pupillary function/reaction. Cranial nerve number 8 is vestibulocochlear. Its intactness is tested by the doll's eyes test and the cold calorics assessments. We'll get to that further along into the video. The brain's blood supply and neuroanatomy is important to understand and have a basic concept of. That way, when there is blockage or bleeding, you'll know what area of the brain that leads to. The basal vertebral artery supplies the lower areas of the brain and the brain stem, while the bilateral carotid arteries supply typically the upper areas of the brain, while the left internal carotid is dominant for most people. This is the view of the brain supply. The picture on the left shows the basal vertebral artery and shows that it supplies most of the brainstem and lower areas of the brain. The brain's anatomic locations will not be knowledge-based. For example, they will not ask you the frontal lobe is responsible for what. They're going to ask you if someone strokes out in this area of the brain, how would they present, that sort of thing. So the frontal lobe is the long-term memory, abstract thought, and personality. The temporal lobe, hearing, interpretations, sense and smell. Occipitals, vision, visual recognition, and reading comprehension. The parietal lobe, object recognitions by size, weight, shape, and body part awareness. And the cerebellum is coordination, balance, and gait. So there's many components for the neurological assessment, starting with the most one we often think of is the level of consciousness. Just note for the CCRN, a change in level of consciousness is always the first sign of a neuro problem, with the exception, and only one exception, of an epidural hematoma that can cause the pupillary changes before a level of consciousness change. Now, which one was the pupillary change? Which cranial nerve? It's cranial nerve number 3, not number 2. So this is the Uncal herniation. That's the only exception. All other exceptions include, or all other examples include the level of consciousness being the first assessment that we notice of change. So that is the only exception. All other areas are going to demonstrate a level of consciousness change first. So your second mental status assessment is arousability. Do they open their eyes when you walk in the room? Do you have to wake them up by voice, by shaking, or pain? That's the Glasgow Coma Scale, and we'll go over that further in the video. Next is the orientation, time, person, place. Again, that's the Glasgow Coma Scale, and we'll go over that. The reticular activating system is important to understand. It's actually a network of neurons connecting the brainstem to the cortex. So it's two parts, the lower and the higher. Both need to be intact for consciousness to be achieved. If one or the other is damaged, you're going to have a lower level of consciousness. The other component is your speech and language. Again, that's part of the Glasgow Coma Scale. The Broca's area in the left hemisphere is responsible for speech. This can demonstrate expressive or receptive aphasia if damaged. And if you don't remember, expressive is the inability to speak or demonstrate an ability to express someone's thoughts or feelings appropriately. And receptive aphasia is the opposite. They might be able to speak or tell you what they need. However, when you speak back to them, they're probably not going to understand you or get a distorted sense of what you're trying to ask them. Memory is the other component. Short-term memory typically becomes abnormal before long-term memory. Attention span and thought, content, and judgment also can be affected. This is why people can remember their family members and where they lived, and not remember you walking in the room and giving them their medications earlier that morning. Personality can also be a first sign of a problem, especially in brain tumors. The patient's personality certainly can change. A person may become more aggressive or exceptionally nice. That'd be nice for all of them to be exceptionally nice. That could be certainly a problem neurologically. Crossing of the motor fibers occurs in the medulla, and motor problems are contralateral to the problem. So if this means this is essentially why there's a deficit on the right side of the body if there is a left-sided brain deficit. Strength and movement are also indicators of motor function. Again, this is part of your neuro assessment. One of the assessments you could do is to ask the patient to close their eyes and hold out both arms with their palms up and hold for 15 seconds. You assess this having weakness by if one of those arms drift down and within the 15 seconds. Also, if the patient has abnormal flexion or distension, decorticate or decerebrate. Flaccidity indicates medulla dysfunction. Sensory function includes assessing the deficits generally the same size as motor deficits. So if one person is flaccid on the left side, typically they can at the same time lose sensory function as well on that side. However, not always. Pupillary assessment. This is one of the ones we look at for a good neuro exam. Pupillary response assesses cranial nerve number 3, like oculomotor. So the sympathetic effect on the pupils is dilate, and the parasympathetic effect on the pupils is to constrict. So if you have a person with a stroke on the left side of their brain, their left pupil will typically dilate. Changes occur on the side of the injury, which is ipsilateral. Don't forget that you can have injury on both sides at the same time, so that would be bilateral. Reflexes are an important part of neuroassessment, and there'll be a fair amount of questions on the neuro section of the CCRN. Your Babinski reflex is back again. It's not only in the newborn assessments, but it's also in abnormal assessments for your neuro. So positive in adults is abnormal. That's when you stroke the bottom of their foot towards the toes, and the toes flare upward. That is positive. Normal is no response or the absence of the flare. Brainstem reflexes are also assessed if all other reflexes are absent and brain death suspected. Now, just because they have no brainstem reflexes does not mean that they can be legally called brain dead. It's important to understand that for the test. There's a process you have to go through. Part of these brainstem reflexes are the cough, gag, and corneal reflex, and the oculocephalic reflex, which is where we test in the doll's eyes. To test the doll's eyes, you're going to make sure first that your C-spine is cleared, because we don't want to turn the patient's head and ending up causing more damage. For the doll's eyes, the patient's eyes are held open, and eye movement is watched as the head is rapidly turned from side to side. Now, we don't want to keep doing this. It's just, for example, if you're going to assess the eye movement to the right, you want to move your head to the patient's head quickly to the right. Positive reflex is good. It's good to be a doll, and that means that the eyes move in the opposite direction of the head turn. An abnormal response, there's two of them. The eyes turn to the same side as the head being turned. So if you turn your head to the right, or the patient's head to the right, and the eyes go with the patient, that is abnormal. And the other abnormal is the eyes do not move either side as the head is turned. That means they stay midline. That is abnormal. The oculovestibular reflex assessment is for, again, just like the doll's eyes, is for the cranial nerve number 8. For the cold calorics test, the test is positive if the eyes move toward the side of the ice water injection. Positive reflex is good. Abnormal is bad, and this is when the eyes do not move toward the injection, or the eyes do move, but they move to the opposite side of the injection. The oculovestibular reflex is the cranial nerve number 8, just like the doll's eyes, and this is when the eyes are held open while ice water is injected slowly into the ear canal. So here's an example of the test here, the cold calorics test. Ice water is injected into the right auditory canal, and the nerve signal travels up the branches of the nerves. Again, so the normal response is if the eyes move slowly towards the side of injection, or if they move the opposite, it typically would be a little more fast, and that's abnormal. So again, here is the response here. So remember that for cranial nerve number 8, cold calorics test. You do not have to memorize this diagram. Other signs that we could look at to indicate a neurology problem is the vital sign changes. One of the hallmark signs is the Cushing's Triad. This is 3 signs that we look for, and if you get them, you know that it could be really, really bad. So this is a sign of herniation of the brain. So this is a late sign, not an early sign of a neuro problem. So the signs are increased systolic blood pressure and a widening pulse pressure. So this means typically the diastolic is going to stay about the same while your systolic blood pressure rises. Also a decreased heart rate and a decreased respiratory rate. So that's Cushing's Triad. Just some respiratory patterns associated with brainstem abnormalities. If you have a midbrain problem, that is a hyperventilation typically. The Pontine problem is apneutic breathing. That's important, I've got that starred. So if you have an infarction in the pons, which is brainstem, you're going to have apneutic breathing. Medulla problem, that's ataxic or respiratory arrest. That's also important. Other important assessments include the following: trauma, drainage, meningeal irritation, abnormal ICP waveforms, radiology studies, chemistries, and so on. So we'll get to that. This is the Glasgow Coma score. It scores your best response: eye response, motor response, and verbal response. So if they hit it once and they don't do it again, that's your best. 8 or less of a GCS score is poor prognosis. So for example, you walk into the room, patient only wakes up to verbal command, only localizes to pain, doesn't obey commands, and tries to talk to you, but it's inappropriate words and crying. That is going to be a score of 11. Moving on, Homonymous Hemianopsia. This is loss of vision in half the field of vision in each eye. So this indicates cranial nerve number 2 damage. This occurs opposite side, so this contralateral of the problem, which could be a stroke or tumor causing this. This results in the neglect to the affected side. So, for example, if they have left-sided Homonymous Hemianopsia, then they're going to be blind in the left side of their field of vision in each eye. So I've got a picture there below, and so that means that patient would neglect the left side of their field of vision. It's important to understand the different pathologies of the neuro. However, the same principles generally apply. The eyes typically deviate toward the problem. Pupil changes are ipsilateral, which is the same side as the problem. Remember, you can have problems on both sides. Visual changes are contralateral to the problem. So again, if you have a pupil constriction or pupil dilation on the left side, your visual changes are going to be on the right side, because those are 2 different cranial nerves. Cranial nerve number 2 is the vision. Cranial nerve number 3 is the ocular motor. Cannot stress that enough from the test. Motor changes are also contralateral to the problem. Babinski's are contralateral as well. Again, that's part of the motor changes. And pathology on both sides, Babinski is bilateral, just like the pupil changes. All right, this is a brain herniation. This is an easier concept to understand. There's 2 types that are most tested on: Uncal or central, transtentorial. This occurs when swelling within the brain becomes so severe that structures of the brain are squeezed to the point where blood cannot get to the brain. So this is when death occurs. So there's so much pressure that there's no perfusion of brain tissues, and which causes brain death. There's other brain herniations to understand, and I have them pictured here, but we won't go over them, which is against the brainstem, and this causes the 3rd cranial nerve to be compressed. This is why the first neuro change that you notice is the change in pupil, not level of consciousness. And this is, again, the only exception. Any other exceptions or any other examples, the level of consciousness would be the first neuro assessment that we notice. The second one that is most common is the central or transtentorial herniation. This is swelling on both sides, which causes the downward displacement of the hemispheres. usually due to diffuse edema, and takes longer to develop than the Uncal herniation. In the beginning of this, there's a slight change in the level of consciousness, and then there's coma. And that's when you could see the Cushing's triad, the increase in systolic blood pressure and the widening pulse pressure, the decreased heart rate, and the decreased respiratory rate. So this is an example of the pupil changes. And in this case, you could certainly have bilateral Babinski's being positive, certainly death, and can be caused most commonly by encephalopathy and or a stroke. So encephalopathy, this is a nonspecific term for the diffuse disease of the brain that alters the brain functions or structure. Encephalopathy can occur from hypoxia, metabolic syndromes, hepatic issues, as well as drugs and infection. Signs of encephalopathy could be certainly minor to major, which increases the swelling and intracranial pressure. Encephalopathy can cause loss of memory, decreased cognitive ability, personality changes, agitation. We certainly have had these sort of patients in the ICU, and seizures, coma, and brain death. So treatment for encephalopathy, you're going to identify factors that increase the intracranial pressure. So restraints increase the intracranial pressure. Being supine and the head of bed flat will increase that. So no hypotonic IV fluids either. There are two kinds of stroke tested on the CCRN exam, and that's embolic/ischemic and hemorrhagic. So there's 3 points to know about the embolic stroke or ischemic stroke. That is a transient ischemic attack, TIA, an RIND, which is an irreversible ischemia neurological deficit, and a cerebral infarct. The TIA is short-term, 24, 48 hours. The RIND can last 1 to 2 months, 3 months, and then the cerebral infarct, of course, is permanent. Hemorrhagic strokes can be intracerebral, subarachnoid, AV malformation, and can just generally cause bleeding, and is typically less common than the ischemic strokes, significantly less common. Assessments for strokes. A right brain bleed or infarction, the eyes will deviate toward the pathology. You have left-sided muscle weakness, left-sided homonymous hemianopsia, left-sided Babinski, and emotional lability. Again, for your left side brain bleed or infarction, your eyes are going to deviate to the left. Right-sided weakness, right-sided homonymous hemianopsia, right Babinski, and you can have aphasia, expressive, receptive, or global. So this is where the Broca's area comes into play. So for your acute ischemic strokes, the treatment is decreasing your time to treatment. So first you have to rule out hypoglycemia. This can certainly mimic stroke symptoms. So one of the first things you want to do when you assess a patient who has stroke-like symptoms, and then you want to assess your ABCs, your airway, your breathing, and circulation. A lot of people think that you're supposed to treat your blood pressure when it's really high, if you're having a suspected stroke, but you don't want to do that. Lowering your blood pressure can actually reduce the perfusion to the brain that has ischemia already. So you want to keep that blood pressure a little higher, and that way you have your cerebral perfusion pressure higher, and you can perfuse the brain. Of course, IV access and O2 administration, cardiac monitoring is important based on labs, and your CT of the head without contrast is important. So we want to get that done within 25 minutes for the CCRN exam. So then you think, okay, this is an ischemic stroke. What do you do? So you can treat it with thrombolytics or supportive care. So how do you know if you're going to give thrombolytics? Well, you're going to look at when the stroke symptoms started, and then you're going to consider the patient's history. So just generally, if you have the onset of stroke symptoms that are less than 4.5 hours and the CT is negative for hemorrhagic stroke and no bleeding, and there's no contraindications for thrombolytic therapy, then your TPA can be used. So the contraindications for thrombolytic therapy includes evidence of a hemorrhage, stroke, or head trauma in the past 3 months, history of intracranial hemorrhage, major surgery in the last 14 days, active bleeding in the past 21 days, an MI within the past 3 months, serum glucose of less than 50, an INR greater than 1.5 if on warfarin, and has a non-compressible arterial puncture. Or if the blood pressure is consistently higher than 180 systolically or 110 diastolically. So TPA administration, your dosing typically is not on the CCRN test, but just be aware of the concept. That's listed here. Post-TPA care or post-thrombolytic administration, you're going to be looking for signs of bleeding, watching for intracerebral hemorrhage, which again is your change of level of consciousness first. You're going to be watching your blood pressures. You want it less than 80 typically. Again, not much lower. You want that cerebral perfusion pressure to remain fairly on the high side, so your brain's being perfused. And you're going to be doing supportive care, so they may have residual neurological defects despite the thrombolytic therapy. Again, if you have an infarct in the pons, you're going to think the 3 Ps: apneustic breathing pattern, pinpoint pupils, and parasympathetic innervation. So Pontine, infarct, PPP. Subarachnoid hemorrhage, this is 5% of all strokes. Common causes are trauma, rupture of an aneurysm, or tumor. Usually presents in 50 to 70 years of age due to the risk of developing an aneurysm with increased age. This can cause hydrocephalus due to arachnoid villi being unable to reabsorb the cerebrospinal fluid. With the subarachnoid hemorrhages, there's the Hunt and Hess grading scoring system. You may have heard of this. This will help determine the need for immediate treatment. The Hunt and Hess grading score for a subarachnoid hemorrhage includes the following. Grade 1 is an asymptomatic or mild headache, slight nuchal rigidity. Grade 2 is a patient's alert and oriented. However, it may have a stiff neck, cranial nerve palsy, and diplopia, ptosis, and dilation. Grade 3 is being drowsy or confused, stiff neck, a mild focal neurological deficit. Grade 4 is stuporous, moderate, or severe hemiparesis and mild posturing. And grade 5 is coma and posturing. So it's important to note that if grade 3 or higher, so grade 3, 4, or 5, there's a decreased level of consciousness. The triad of an aneurysm rupture is pretty classic here: sudden explosive headache, decreased level of consciousness, nuchal rigidity, and positive Kernig sign. And we'll go over the Kernig sign shortly. Surgery within 48 hours if the Hunt-Hess grade scale is 1, 2, or 3. Surgery may be delayed if the grades 4 or 5 are there, just because based on the outcome of the patient. So again, the subarachnoid hemorrhage complications, hydrocephalus, and vasospasm and rebleed. Those are one of the dangers post-op or after your arachnoid hemorrhage. So the vasospasm occurs in 40 to 60% after the initial bleed, and usually occurs 5 to 7 days after the bleed. This can be associated with hyponatremia. Triple H therapy is controversial, but it can help to prevent vasospasm. This is diagnosed by transcranial Doppler or arteriogram. Rebleeding is also possible after the initial bleed, so this is more common 7 to 10 days after the initial bleed, with peak incidence typically 4 to 8 days after. This is the greatest cause of death, and an antifibrinolytic prevents rebleed. So giving Amicar helps prevent the rebleed there. It's important to know that vasospasm is more common than your rebleeds. So it's important to prevent vasospasm. So some of the treatments for vasospasm is transluminal ballooning. This is the Triple H therapy. It's controversial. So making the patient hypervolemic, we're using crystalloids, colloids to keep your central venous pressure to 10 and keeping your pulmonary artery occlusion pressure to 16 to 18. Hemodilution, you want to give the fluids to reduce the hematocrit to 30 and keeping the patient hypertensive to keep the blood pressure 160 to 200. This will, again, increase your pressures, which will help prevent vasospasm. Though it is controversial, it may be on the test, CCRN test. However, if it's not, it's important to remember that hypotension and post-op or people post subarachnoid hemorrhage, hypotension should be avoided. You can also prevent vasospasm by administering nimodipine. The AV malformation, the arteriovenous malformation, is congenital. This is when there's a tightly tangled mass of dilated vessels that shunt arterial blood into the venous side without the typical connecting capillaries. Some of the signs and symptoms of the AV malformation is hemorrhage, most commonly. However, those are small AVMs. Seizures are second most common. This is usually associated with larger AV malformations. Other symptoms, of course, include headache, progressive neurological deficits, possible hydrocephalus, and neuropsychiatric manifestations. Treatments for AV malformations include surgery and radiation. Embolization, however, is not curative, but may be used prior to surgery to decrease the risk of bleeding. This can be done given a catheter through the femoral artery. Brain tumors, this is important to know. Early manifestation of brain tumors includes seizures and is associated with high mortality rate. Even, a lot of people think that brain tumors are cancer. A lot of them are benign, but they can still cause death due to compression of the neuroanatomy or increase in your intracranial pressures. So what are things that increase the intracranial pressure? You really have to understand this for the test. Generally, this is the first sign of a neurological problem, again. The normal ICP is 0 to 10. These numbers are going to vary depending on what source you use, but just in general, the normal ICP is 0 to 10. Moderately high is 10 to 20, and increased is over 20. It's important to maintain cerebral perfusion pressure during this elevated ICP. So how do you know your cerebral perfusion pressures are high enough? You can calculate this by taking your mean arterial pressure and subtracting the intracranial pressure. So the goal of cerebral perfusion pressure is 60 to 80. Again, these numbers will vary, depend on your source. And the minimum, however, is 50. Just know that brain death can occur with CCP of less than 30. And understanding that hypotension, again, is not very good for the patient. If you have increased intracranial pressure and your cerebral perfusion pressure drops too low, then your brain is no longer being perfused, and that equals brain death. So when your ICP is elevated, you want your cerebral perfusion a little on the higher side. So the goal is at least 70, but you can do 60 to 70 to 80. Signs of increased intracranial pressures are altered level of consciousness, restless agitation, seizures, cranial nerve palsies, 3, 6 through 10, headache, nausea, vomiting, visual dysfunction, motor dysfunction, pupillary changes, and Cushing's triad. What's Cushing's triad again? It's the widening pulse pressure with increased systolic blood pressure, decreased heart rate, and a decreased respiratory rate. ICP monitoring can be used during use of a fiber optic catheter or a fluid-filled system. Using the fluid-filled system, the transducer should be at the level of the foramen of Monro. This is right at the ear, right there on the side is your external auditory meatus. Indications for ICP monitoring include head trauma, a Glasgow coma score of 8 or less, or post-op neurosurgery. So it's 3 waves that we're looking at on the ICP monitoring: C waves, B waves, and A waves. The C wave is a very common wave and is good. It's basically small variations in the ICP, which we don't see across time. We don't see very many changes. The B waves are bad waves. Again, these are waves you're gonna make sure first that the transducer is at the right level and that your drain is zeroed. But these are bad. These are fluctuating ICP over time. You got to think what's causing this. Is your patient in the right position, or are they midline? Is a catheter working? And then A waves are awful. So this demonstrates at the bottom here, demonstrates a significant variation in ICP pressures. So this is something wrong, and you need to let somebody know immediately. So lowering the ICP includes using mannitol, furosemide, preventing dilation of the cerebral vessels by preventing acidosis. This acidosis causes dilation, and prevent alkalosis, which causes constriction. So you have to really keep them in the middle and maintain their pH in appropriate levels. Your drain can be through an intraparenchymal bolt or ventriculostomy. When you're monitoring the drain, you want to drain the ICP drain if the ICP is greater than 20. Prevention of secondary brain injury. Just going to monitor your ABCs. So you want to control the pH level, avoid hypoxemia, and avoid hypotension. There's a common theme across a neurology review. You want to avoid typically hypotension. You want to avoid typically acidosis. And you want to also prevent agitation and pain, because those also can increase the intracranial pressures. This little bullet point box here have control PEEP levels. People that are on the ventilator, PEEP can increase thoracic pressures, which prevents optimal jugular venous outflow, which again can raise your ICP. Also avoiding low protein. This decreases your osmotic pressure, which causes fluid to go intracellular. Next is traumatic brain injury. The overview on TBIs includes a blunt or penetrating injury. So the blunt would be closed, the penetrating would be open from an external mechanical force. So the diagnostic test for the traumatic brain injury is the CT of the head. In this traumatic brain injury, you have primary brain injury with a potential cause for secondary injury. And this results in temporary or permanent impairments of the cognitive, physical, and psychological functions. The etiology that make up TBIs includes 40% falls, blunt trauma, 16%, motor vehicle accidents, around 14%, assaults, 11%, and other various causes, roughly 19%. Types of traumatic brain injury includes diffuse or focal. So the diffuse TBIs include concussion or diffuse axonal injury. And during the focal, these are contusions, intracranial hematomas, skull fractures, or open head injury. So how do you know how severe a traumatic brain injury can be without imaging? You can look at the GCS. So within the first 48 hours, the GCS can be severe, 3 to 8, moderate, 9 to 12, or mild, 13 to 15. Next is your epidural hematomas. These are hemorrhage. Usually an epidural hematoma is usually due to a meningeal artery bleed related to a temporal bone fracture or temporal bone trauma. This causes bleeding between the skull and the dura of the brain. This can rapidly develop, so you're going to have headache, irritability, confusion, vomiting. Remember that ipsilateral pupil dilation before level of consciousness. Remember, this is the Uncal herniation. And it can be contralateral involvement of hemiparesis and hemiplegia. So the late sign of an epidural hematoma is the decrease in level of consciousness, and treatment is going to emergency surgery using a burr hole to evacuate the hematoma and monitoring and treating intracranial pressure. So the other type of brain hemorrhage is the subdural hematoma. So you have subarachnoid, epidural, and subdural hemorrhages. So the subdural hematomas are 50 to 70% of all hematomas. This can occur, again, due to trauma or spontaneous development. These are more common in elderly or alcoholics, and this is due to falls. These are types of subdural hematomas. This is how we classify them: acute, subacute, and chronic. The acute is within 24 hours. The subacute hematoma develops within 2 weeks, and the chronic hematoma develops over a period of 2 weeks or greater. The clinical presentation of subdural hematomas includes those similar to an epidural hematoma. However, there's less vomiting, and pupil change usually comes after the level of consciousness. This may develop more slowly than the epidural hematoma, as we mentioned in the previous slide. Treatment includes a close neuroassessment for signs and symptoms of increased intracranial pressure, surgery to evacuate the hematoma. And here's a picture that you can see the different types of hematomas. So the last one we're going to mention is the intracerebral hematoma. And its common causes is from a depressed skull fracture, gunshot wound, severe acceleration deceleration injuries, such as those in a motor vehicle accident, and can be non-traumatic from strokes. This is 2 to 20% of all hematomas, and the clinical presentation can vary greatly due to the area of involvement. So you may or may not have increased intracranial pressure, but you still need to monitor for it. Treatment for intracerebral hematomas include surgery if there's a large bleed and accompanied by a decreased level of consciousness. Skull fractures are typically the easier portion of the CCRN test, so we'll go over those. The most important one to remember is the basilar skull fracture, and again, what is that associated with as far as cranial nerves? It's cranial nerve number 1 we want to be able to monitor or assess for. The types of skull fractures include linear, open or depressed, comminuted, or the basilar skull fracture. So the linear does not typically require surgery, and for the tests, the open or depressed skull fractures greater than 5 millimeters, you have to have surgery for the test. So if you have a 6 millimeter depressed fracture, you're going to have surgery. So basilar skull fracture, the patient is typically going to present with raccoon eyes, which is the periorbital edema and ecchymosis. So these patients are going to look like they have darkened areas around their eyes. Battle sign, which is the discoloration in the back of the ear. Otorrhea, which is fluid from the ear due to meningeal tear. And rhinorrhea, which is fluid from the nose due to, again, a meningeal tear. If they have rhinorrhea, It's important to educate the patient to not blow their nose. They're going to want to because they're going to feel their nose draining. But if that's CSF fluid, we do not want them to blow their nose. And these patients also lose cranial nerve number 1, no sense of smell. This can be permanent. So if there's clear fluid coming from the nose or ear, it's more than likely CSF, but to test for it, you're going to test that with a glucometer. If it has glucose in it, it is CSF. Or if there's blood in the fluid and you don't know if it's clear or not, you want to put that drainage of blood onto a 4x4 gauze. And if it has spinal fluid in it, you'll see a blood clot surrounded by a yellow halo, which is called the halo sign. So if you see on a question a basilar fracture and a patient has a bloody nose, you're going to educate the patient not to blow their nose. And you're also going to test that for CSF, which could be halo sign or glucose. It's important to note that if you have blood, you're going to have glucose automatically. So the only test that's going to be accurate for the blood is putting that drainage on a 4x4 gauze. So if they do have drainage from the ear or nose, it's important to cover their ear or nose with dry sterile gauze and not to pack it in. You don't want to cause a blockage of the CSF drainage that can increase your intracerebral pressures. So there's also a risk of meningitis because you've torn the meninges, and so you're going to monitor for infection. You also are not going to introduce a nasogastric tube. You only want to use an orogastric tube. Seizures. These are actually most commonly self-limiting to 3 minutes or less. However, you want to be able to monitor for the patient after the seizure, for the post-ictal period. The PaCO2 is probably going to be elevated due to abnormal ventilation. So you want to be able to protect the airway if the patient's seizing. You want to turn on their side. And you want to stop the seizure using Ativan or diazepam, 8 milligrams max for this test, and diazepam 30 milligrams max for the CCRN test. To prevent the seizure, you can use phenytoin, which is Dilantin, 1 gram is max, or phenobarbital, 5 milligrams per kilogram with a 50 milligram per minute max. And you want to just understand what drugs to use. You don't necessarily have to remember the doses. It's important to remember that patients can have a decreased level of consciousness immediately post-ictal. And if you fear that you've given too much Ativan or too much diazepam, you can give a benzodiazepine reversal, which is Ramazocan. However, you need to watch for the redevelopment of seizures. The seizure types that's on the test include status epilepticus. This is seizure activity of greater than 5 minutes, and it can be a single seizure or a series of seizures with no return of consciousness between those series of seizures. This is not responsive to usual therapy, such as Ativan or Dilantin. Some of the causes for status epilepticus is withdrawal from anticonvulsive medication, acute alcohol withdrawal, toxic level of drugs, CNS infections, brain tumors, CNS trauma, metabolic disorders such as hypoglycemia, hepatic failure, hyponatremia, hypocalcemia, and hypomagnesemia, and also stroke. So what happens during this? Early, there's increased cerebral blood flow, tachycardia, hypertension, and increased glucose from the stress response, and also an increase in potassium from skeletal muscle cell destruction, and increased PaCO2 and decreased PaO2. Later on in the seizure, cerebral blood flow is unable to maintain demands, so you end up with cardiac arrhythmias from hyperkalemia, hypoglycemia from metabolism in the brain, increased potassium and CK levels, rhabdomyolysis, and ventricular fibrillation. Death from status epilepticus is due to cerebral hypermetabolism. Meningitis is also on the CCRN test. So this is monitoring or assessing the cerebrospinal fluid. It's important to do if you suspect meningitis. Understand that the CSF is produced in the choroid plexus and is absorbed by the arachnoid villi. So again, in your subarachnoid hemorrhages, you can block this arachnoid villi and cause increased intracranial pressures. Normal glucose in CSF is about 60% of the serum glucose. Normal protein in CSF is about 20 to 45 milligrams per deciliter. Normal LP pressures are between 80 and 180 centimeters of water. So assessing these, you're going to determine if this is bacterial meningitis or not. In the cases of bacterial meningitis, you're going to treat aggressively with antibiotics. You must know the signs of meningeal irritation and the presence of bacterial versus viral meningitis, and we will get to that in the next slide. So for bacterial meningitis, you have a severely increased protein in the CSF. You're going to have decreased glucose, severely increased white blood cells, purulent CSF, and an open and L-pre pressure of greater than 180 centimeters of water. In viral meningitis, you're going to have increased protein, but it won't be nearly as much as the bacterial. You're going to have normal glucose typically in viral meningitis. You're going to have some increased white blood cells, but you're not going to have the serious increase that's in bacterial meningitis. You're going to have clear CSF. The opening LP pressures can be normal. So in meningitis, bacterial and viral both have signs of meningeal irritation, so which is one or more of the following: headache, nuchal rigidity, Brudzinski's sign, or Kernig's sign. In Brudzinski's sign, ask the patient to put their chin to their chest, and their legs are going to come up from the pain. In the Kernig's sign, you ask the patient to put their legs up and out, and they're going to experience pain in their neck and legs. So that's one of the signs of Kernig's sign, and the sign of meningeal irritation. So that's when you suspect meningitis. CCRN also covers brain death, and this is the complete irreversible cessation of function of the cerebellum, cerebrum, and the brain stem. If the patient's in a coma, that it is irreversible and you know why this coma is happening, that the neuroimaging explains the coma, that you've removed all CNS depressant drugs, there's no evidence of using paralytics, there's absence of severe acid-base imbalance, so you have to have a significantly normal pH level, there's normal body temperature or mild hypothermia, systolic BP has to be greater than 100, and no spontaneous respirations. So this is the condition that the patient needs to be in before you can test for brain death. So brain death, your examinations are going to include pupils that are non-reactive to bright light. The corneal reflex is absent. The oculocephalic reflex is absent. Remember, you're only going to do this cranial nerve 8 assessment if the C-spine is cleared. Also, the ocular vestibular reflex is absent. Remember, that's the cold calorics. No facial movement to stimuli at the supraorbital nerve. No gag reflex, no cough reflex, and absence of motor response to stimuli in all 4 limbs. So for the brain death determination, you're going to do an apnea test. And the prerequisites to an apnea test include the core temperature being 36.5 degrees Celsius or greater, a systolic blood pressure of 90 or greater, a PaCO2 of greater than 35, and absence of drugs to cause respiratory depression. And before you do this apnea test, you're going to want to pre-oxygenate for 20 minutes at 100% oxygen prior to ventilator disconnection. There's 4 indications for stopping the apnea test early. If you notice spontaneous respiratory movements, if the systolic blood pressure is less than 90, if the SpO2 falls below 85%, or there's a development in a cardiac arrhythmia, as far as unstable cardiac arrhythmia. So after 8 to 12 minutes from the apnea test, you're going to obtain an ABG, connect a ventilator, and then interpret the ABG results. So the apnea test is positive, which supports brain death if absent respiratory movements are noted, and if the PaCO2 is greater than or equal to 60 or 20 over baseline. The apnea test can also result in a negative test, and the test can be negative, which does not support brain death, if respiratory movements are observed. And this is indeterminate if the apnea test is terminated early, or the PaCO2 is less than 60, or less than 20 above the baseline. We're almost to the end here. We're going to get to Guillain-Barre and a few other neurological syndromes. 50% of Guillain-Barre cases are from viral infections, most commonly the parainfluenza 2, measles, mumps, and herpes zoster. And people may not know it, but the flu shot can actually cause Guillain-Barre, and I actually know 2 people that have had it from the flu shot, and that's 15% of cases. That's quite a high amount of number. Recent surgical procedures can also cause it, and this is less common than even the flu shot. Pathophysiology of Guillain-Barre includes demyelination of lower motor neurons, which affect the spinal cord and cranial nerves. Guillain-Barre presents ascending nature, which is ascending paralysis, usually symmetrical, which occurs proximally. Late stages of Guillain-Barre can include the diaphragm, which may require the ventilator. One of the ways of assessing Guillain-Barre is having protein in the CSF. It's important to note that there's no alteration in consciousness in Guillain-Barre syndromes. So all of a sudden, your patient comes in and has a foot ulcer or is sick or gets the flu shot, all of a sudden start experiencing weakness, and it gets progressively worse, ascending, and then all of a sudden they can't breathe and they can code. So you have to be careful and watch for that. And through all this, they're not altered as far as their mentation. Treatment for Guillain-Barre includes monitoring your respiratory failure and monitoring your urinary output for retention, because you can have a neurogenic bladder. Intubation and mechanical ventilation for respiratory failure is usually warranted. You're going to give them corticosteroids, intravenous immunoglobulin, IVIG, and plasmapheresis to remove abnormal antibodies that affect the myelin sheath, which can lessen the severity and duration of Guillain-Barre. The next is Myasthenia Gravis. So it's important to understand that Myasthenia Gravis is grave muscular weakness. This is an autoimmune attack on the neuromuscular junction, and the clinical presentation includes progressive skeletal muscle weakness. Early is easily fatigued, and late includes paralysis. 70% of these patients have ocular dysfunction, diplopia, ptosis, and trouble keeping the eyelid closed. Also, patients in myasthenia gravis can have dysarthria and dysphagia. Treatment for myasthenia gravis includes which presentation they're coming through. So this can be myasthenic versus cholinogenic crisis. Myasthenic crisis includes the deficiency of acetylcholine, which may be due to underdiagnosed or undertreated and acute exacerbation of myasthenia gravis. And a cholinogenic crisis includes an excess of acetylcholine due to overtreatment. So since both of these present the same way, you're going to differentiate this, at least for the CCRN test, by the tensilon test. In myasthenic crisis, the tensilon 2 mg IV causes clinical improvement, so a decreased muscular weakness. In cholinogenic crisis, the tensilon IV can cause increased muscular weakness. So in this case, there's an acronym SLUDGE. You want to remember in myasthenic gravis patients, salivation, lacrimation, urination, defecation, intestinal distress, and emesis. So treatment of myasthenia gravis is given cholinesterase inhibitors. This prevents cholinesterase from breaking down the acetylcholine. You could also have surgical removal of the thymus gland, give steroids and immunosuppressants because it's autoimmune. Plasmapheresis, again, and give an IVIG. So it's important to not get myasthenia gravis or Guillain-Barre mixed up, and their treatments. The treatments are very similar, but again, with myasthenia gravis, you're going to give cholinesterase inhibitors. For both, you're going to give plasmapheresis and IVIG and steroids. Okay, the last section is muscular dystrophy, and then we'll be finished. So muscular dystrophy is several types, but it's a group of inherited progressive disorders that results from defects in the genes required for normal muscular function. Two of the types that can be on the CCRN test is Duchenne and Becker. It's important to know that these patients have progressive muscle weakness, which is myopathy, and loss of muscle mass, which is atrophy. Typically, in muscular dystrophy, the weakness starts near the trunk and spreads to the extremities, which also affects more commonly the legs before the arms. So Duchenne muscular dystrophy is onset very early in life, and often the patient is wheelchair bound by the age of 12. Most DMD patients die within their late teens or early 20s due to respiratory infections or cardiomyopathy. Treatment for DMD includes steroids, pneumococcal and influenza vaccines. You want to monitor their heart functions and give ACE inhibitors and beta blockers. These are going to help from the development of cardiomyopathies. Baseline pulmonary function tests, nocturnal ventilator supports, and caution with anesthesia and sedation, as these patients are more prone to malignant hyperthermia. In Becker muscular dystrophy, this is typically onset later in life and more often more mild than Duchenne's muscular dystrophy. Often these patients can walk until the late teens, with some walking as adults. And these patients typically survive into their 40s, and the most common cause of death, again, is heart failure from cardiomyopathy. Treatments for this type of muscular dystrophy, as with many, are steroids, pneumococcal influenza vaccines, monitoring their heart function, again, baseline PFTs, ventilator support, and being precautionary with anesthesia and sedation. Thank you for watching. For more CCRN practice videos and questions, please visit lifelongnursing.com. And if you like this video, please like, comment, and subscribe.